Welcome to another session of Decoding DX. We are very honored to have Dr. Abebe back with us again, the one and only. And then we have new guest discussant, Jessica. She's a third year at KU. I'm super excited to have her here with us. And John is going to walk us through an awesome case today. So I will go ahead and share my screen so that we can see. Let's do this one. Alrighty. And then we will go ahead and get started. John, please take us away.
Gotta remember to unmute myself. Okay, so we have today a 31-year-old male who presented to KU with intractable nausea and vomiting. So we'll just kind of get into the history. One thing that we really want out of these cases, and we kind of have gotten some feedback that we want to focus in on, what do we do management wise? So we'll talk about differential and what we're thinking, but we'll talk more about the history, and then we can move on from there, because that's a very broad differential from there. Okay. So this 31-year-old gentleman, he came in, he's had intractable nausea and vomiting for the last 3 months. He said it's been pretty miserable. He cannot take in any food whatsoever at this point. He said it's progressively been getting worse. At this point, he will eat, and then about 20 to 30 minutes later, he'll vomit it right back up. The only thing he's really able to keep down is fluids periodically. He denies that the food ever gets stuck. He hasn't had any issues with like chest pain after eating or regurgitating immediately. It sits for a little while and then it comes back up. His vomit has always kind of been his gastric contents. He's never had any blood in it, never had any bile, never was feculent or was some sort of intestinal secretions. He has had a little bit of abdominal pain. It's kind of diffuse, but no sharp localized pain anywhere. He has had some heartburn periodically that he's been treated for in the past with a PPI and Tums. And then significantly, he's had, over this past 3 months, he said that he's had about a 40 to 50 pound weight loss. And it's not something that he's been trying to do. He just said he just is not eating through this whole time. He hasn't had any diarrhea. He hasn't had any blood in his stool. He hasn't noticed any fatty stools or things that are floating to the surface. And overall, he's just very understandably distraught and anxious. So even the thought of eating right now is causing him a lot of anxiety. So kind of at this point, I think it'd be a good time to kind of think about, Jessica, when you see someone with nausea and vomiting as your chief complaint, what are some things that, do you have kind of a thought process that you kind of break up your, have an idea with, essentially?
Yeah, so I like to go with kind of a triage mechanism where what can kill the patient first, and then kind of move down to more benign causes. And so do you want like so right now when you said weight loss and he had some other kind of, I guess, alarm symptoms, I would think, oh, maybe this is kind of a malignancy. Maybe we should evaluate for us cancer. And then that'd be like my acute something going, or not acute, but more malignant cause. And then a benign thing would be maybe he just has some sort of diabetic gastroparesis. It's causing them a little bit of vomiting.
Mm-hmm. I think that's a good thought. I think another thing that I kind of like to think about is I I think there's a good way to break it down is number one, medications is a huge one that I always think about when I see a patient like this. Are they taking something that can be associated with that? And then are there like disorders of the GI tract? So something like a gastric outlet obstruction, something like, small bowel obstruction, anything that can cause a mechanical obstruction that would cause nausea and vomiting, or like gastroparesis, like you mentioned. And then infectious is a big one. And then another interesting one, kind of to break this down in this kind of picture, is also any kind of neurologic system is another one. So if you have, the classic kid waking up in the morning vomiting, you think about CNS malignancies, things like that. But anything that can increase your hypertension or increase your CNS pressures can cause some of that nausea and vomiting, and kind of that cyclical picture in which our guy has kind of had. So let's go and add a little bit more history for him. Other review of systems before getting into his past medical history. So review of systems, other than what he's mentioned, he's also recently been noticing some numbness in his hands and his feet. That's been going on just for maybe the last month or two. He hasn't really noticed anything specifically that brought that on. He just has kind of noticed it slowly. And then his past medical history was significant for asthma. He's just been treated with an albuterol inhaler. That's his only medication that he's been taking. And then he was seen at an outside hospital for this in the past, but they did a pretty extensive workup and they didn't find anything wrong with him at the time. So at this point, I guess I'm curious, Dr. Abebe, when you hear this kind of presentation, are there any other questions that we kind of haven't talked about that you would really want to ask this person to make sure we're ruling out something?
I think that was a very nice breakdown. In general, when I have someone coming in with nausea and vomiting, I kind of put in my mind whether this is a primarily gastrointestinal or intra-abdominal versus extra-abdominal processes. And then my third category is kind of like miscellaneous, which probably include medications, like you said. One thing you'd want to know and chronicity has to do initially, which was described whether this is acute or chronic. And then I would look at common medications that patients are taking, but we should also think of substance use disorders, thinking in the line of cannabis. Patients may not tell you that they're using that, so always think of that as well. And so if you go back to the intra-abdominal, I kind of break it down as something mechanical, inflammatory, like conditions like appendicitis, hepatitis, and then pancreatitis are things that I would definitely be looking for. In addition, I would also be thinking about an infectious process. Patient doesn't have fever, and this is very chronic, so a gastrointestinal, viral, and bacterial infections are quite important to remember. The other thing I would also remember is here we're talking about the causes, but we should also think about the resultant effect of someone who hasn't been eating for a while from a standpoint of nutritionally and hydration status. So we should also be mindful that, folate, we don't usually are able to store more than a few days. So it may have a folate deficiency or may have a B12 deficiency. So one thing that probably stands out for me is this has gone for 3 months, nutritional deficiencies as a result of, ongoing loss, or I would rather say ongoing inability to hydrate themselves or take nutrition, has to be taken into consideration. And then, patient doesn't have any non-chronic medical illnesses. Other things that I would always think of nausea, vomiting would be, does patient has chronic kidney disease, or are they uremic? If this patient has liver disease, are they, this a patient who's got liver cirrhosis and has advanced liver disease, but it sounds like symptoms are exclusively more of an upper GI. And one thing I was going to point out on your symptom was because the fact that patient was presenting with symptoms that are immediately following diet. So this actually makes me think that this is probably proximal to the duodenum, things like gastric outlet obstruction, gastroparesis. And remember, gastroparesis is not always due to diabetes. You should also think of scleroderma. It always comes to my mind. The other thing is amyloidosis. Amyloidosis is another one that you should be thinking about. And obviously, like was discussed before, patient had an intentional weight loss. Could this be, like Jessica said, could it be a malignancy and presenting with a paraneoplastic syndrome? It was a numbness and tingling. This does not. This is not part probably of what I think in the form of endocrinopathies. Always think of endocrinopathies. I would tell you the number of times I had patients with adrenal insufficiency presenting non-specific symptoms of fatigue, nausea, vomiting, abdominal pain, ketoacidosis. Actually, there is always a red herring of ketoacidosis presenting with abdominal pain, just nausea, vomiting, and acute abdomen. I would say this and I'll stop. If you have a patient who presents acutely, I think of vascular phenomena in my mind. Does the patient have a stroke? Does the patient have MI? And you would be really surprised how many times I had a patient who had a posterior circulation stroke presenting with dizziness, lightheadedness, just nausea and vomiting. The other thing I would be thinking about is MI. Myocardial infarction is a big one. And of course, the elephant in the room is mesenteric ischemia. But it sounds like this probably is not how this patient is presenting. So those are things that I would be thinking, I guess. We didn't talk about this. Travel history is very important. Maybe patient had an indolent infection that has, that has been going on for a while. It could be protozoal or parasitic infection, but I guess this doesn't sound like that in my opinion.
All right, that was excellent. Thank you, Dr. Abebe. I think one thing that you mentioned, the endocrinopathies, if you ever rotate on a GI rotation with Dr. Grizzolana, who's one of the KU med doctors, he's famous in the GI department for getting an AM cortisol on anyone with nausea and vomiting because he's diagnosed more people with adrenal insufficiency as their source of nausea and vomiting that no one thought to check. So if you ever rotate with him, you will always see that on his results review. Okay, so getting into our gentleman's vitals, and also when we go through his physical exam, I'm going to stick mainly to his pertinent positives or negatives, just so we can keep it moving. So his temperature, 36.7, blood pressure 122/79, respiratory rate of 16, and an SpO2 of 100%. When you're generally, he appears, not in acute distress. He's resting comfortably in his bed, but he does look underweight significantly, and he also generally looks kind of anxious. When you're doing an HE&T exam, you don't notice any lymphadenopathy, and his conjunctiva and sclera are clear. His heart, no murmurs, regular rate and rhythm, lungs clear, auscultation bilaterally. His abdominal exam, it was soft, non-tender, non-distended, normal bowel sounds, no guarding, no rebound tenderness, no negative Murphy sign, no right upper, no localizing symptoms at all. And then because of his numbness that he mentioned, you do a fairly complete neurological exam. You do his cranial nerves 2 through 12 are intact. His strength is 5 out of 5 throughout. He had normal reflexes, but he had decreased sensation to light touch in his hands up to his mid forearms, and then his feet up to his mid shin. And his proprioception is intact. You weren't a good neurologist and didn't have a tuning fork on you, so you didn't specifically test for vibration though. And then his skin, you didn't notice any rashes, any bleeding at all. So kind of with that information, Jessica, is there anything in that really sticks out to you, or things that you were looking for that you didn't see? Just kind of what are you thinking with that general exam picture?
So like Dr. Abebe said, he probably hasn't ate for a while, and he probably is malnourished. And I was hoping we would do a Romberg test to kind of see about that, a B12 deficiency or some other micronutrient deficiency that could maybe be contributing to those neurologic exams. Other than that, I kind of like the benign, or I guess I don't like the benign abdominal exam, because it doesn't really doesn't help us with really any diagnosis, doesn't sway me any.
Absolutely. I think those are really good points. One thing I was thinking about is, you'll notice that his vitals are normal. We're not thinking infectious. We're not thinking, has he had some sort of weird chronic, this is kind of an acute, but if you were thinking, we're thinking it's this chronic, but if it was more of an acute picture, you'd be looking for any change in his vitals. You also be looking for like a tachycardia in terms, I guess we didn't put his pulse down. His pulse was normal. It was 80. You'd be looking for a tachycardia, looking for any signs of dehydration like that. He really doesn't have that much. And when you talked to him originally, he did say, he's able to keep down fluids for the most part. So that is, that's kind of that. Either Dr. Abebe or Jessica, at this point, would you consult GI, A? And if so, do you think they would do an EGD on this patient? And obviously you get labs and some other stuff. This is a question that often comes up when you're on rounds, someone says nausea, vomiting, you say, can we manage this? Do we need GI involvement?
Go ahead, Jessica, sorry.
Oh, I was going to say the more eyes, the better. So I don't see why not. It might be something where they'd say, oh, that was silly. Why'd you consult us? But it's just nice to have another opinion.
I think I would like to work a little bit more and because the patient has been having the symptoms for quite a while, and I think I will like to do a little bit more investigation. I want to point out that I would characterize the findings as distal sensory neuropathy. So when I have someone with distal sensory neuropathy, the thing that I can always think about are nutritional deficiency, like we talked about, B12 deficiency, but other findings are not consistent with that, but maybe we would know more. This patient is alcoholic, somebody who has been drinking for a while that we are not aware. So alcoholic neuropathy is another one. The other is diabetic neuropathy, distally, but like I said, probably something that we would find out as we go further. The other is amyloidosis, like I said, comes to mind. At least these are the four things that I would think right now. But I think before I go ahead and get gastroenterology, I would probably hold up. I think we would eventually think about that. In my mind, we need to find out what's wrong with the stomach and duodenum, but at least I would like to know whether his hemoglobin is stable. And the other thing I would definitely is he coagulopathic, because if he's nutritional deficient, he could also be deficient of vitamin K. So I would like to do the groundwork first, and then kind of there's nothing wrong, Jessica, to get other minds involved. But in my mind, as an internist, I would like to do the groundwork and reach at a stage where I feel like I will need the gastroenterologist. Because if you tell them that I have a patient who, with this problem representation of 31-year-old who presented with nausea, vomiting, with significant unintentional weight loss, was found to have distal sensory neuropathy, then you should have a sense of what you're thinking before you actually get them involved. And I think somebody said fecal occult blood. So let me get this straight out right away. The only time I would use fecal occult is if I'm doing in an office where I would like to screen for malignancy, colorectal malignancy. So I would just get rid of that. You know, my professor used to say, put your finger in the rectum. If you don't, you'll put your foot in it. So just do that and see if you have grossly melanic or hematochezia with or blood in your finger. So
absolutely, I think those are fantastic points, Dr. Abebe. Yeah, definitely don't suggest to your GI consultants to get a fecal occult. They will be very annoyed with you. They will prefer that you use your finger. And then also kind of a general idea about like EGD versus no EGD, especially if you are at the point where you've done more workup, like Dr. Abebe was talking about. One of the things is if you think about, could these symptoms be a sign of either, like for this kind of nausea and vomiting picture, of an obstructive picture, or if you're concerned about like a GERD or a dyspepsia picture. Those are oftentimes kind of the two things that you're worried about: a gastric outlet obstruction, you're worried about an esophageal pathology. Those are kind of the things that some of the big things that you think about with an EGD. So let's kind of go into some of the labs that you have for our gentleman. So you got a CBC. So your hemoglobin was 9.8, hematocrit 28.4, platelet count of 84, white blood cell count of 3.5 with a normal differential. And then your MCV was 107. And then you had a corrected reticulocyte count of 0.6%. Your CMP, you had a sodium of 144, a potassium of 3.4. The rest of your CMP was normal, and except for you had a T-Billy of 1.7 and a direct Billy of 0.7. You went ahead and ordered that as well. You're concerned about, maybe marijuana use, cyclic vomiting, so you got a urine drug screen, and that was negative. You also got an AM cortisol and a TSH, and those were both within normal limits. And then you also got some imaging as well. You got an abdominal X-ray, which showed non-obstructive bowel gas pattern. And then you also, because you kind of have this nausea vomiting picture, doesn't make a lot of sense, you got a CT head to rule out any CNS involvement, any kind of malignancy, some huge mass that's causing the nausea vomiting, and that was normal, no acute changes, anything like that. So to kind of speed up a little bit, just to think about a little bit about imaging as well, when he was at his outside hospital, he did get an EGD when he was evaluated. That showed direct exam was more or less normal. Biopsy of your gastric mucosa showed consistent with gastritis, but it was negative for H. pylori. And then you also got a CT abdomen pelvis, and it was generally unremarkable. So at this point, with those labs, Jessica, is there some additional labs that you would like to get for our patient?
I'm just thinking, I'm stumped right now. I feel like everything's just been normal.
I don't know is our favorite phrase.
Absolutely. So I'll go ahead and kind of start thinking about some of these labs. So if you notice, he's kind of got a pancytopenic picture, and he's got a macrocytic anemia as well. And you'll also notice that he has what would be an indirect hyperbilirubinemia as well. But generally his other imaging kind of points to no real abdominal pathology that we can see on imaging, at least. So at this point, kind of how what Dr. Abebe had been talking about earlier, we were concerned about essentially B12 or folate deficiency as a lot of those abnormalities of his underlying all of the pictures, like the whole picture of his essentially CBC abnormalities was just kind of concerning for some underlying coagulopathy versus B12 deficiency. So we went ahead and got some additional labs. I'll just kind of run through those, and then we'll kind of unpack our essential one of our diagnoses here. So we got a B12 level, and that was undetectable. We got a folate was greater than 22.3, so that was within normal limits. We got a peripheral smear that showed macrocytic anemia. Ovalocytes were present, and then it showed granulocytopenia and thrombocytopenia. We also got some hemolysis labs because of that hyperbilirubinemia. LDH was 1605. Haptoglobin was less than 30. Both of those are abnormal. We also got a Coombs test, which was negative. And then we got a UA of that showed increased urobilinogen. So at this point, what do you think your diagnosis is, at least from a lab perspective, Jessica?
So from a lab perspective, I'm thinking of B12 deficiency.
Any thoughts on what the underlying cause most likely is based on the other parts? And if you say, I don't know, that is a great answer.
I have a guess that it's some sort of pernicious anemia, but the LDH and the haptoglobins kind of throw me off a little bit.
That is a great point. Go ahead, Brianna.
Yeah, I just want to say, so with the I don't know, that's perfect, because if I had this case, I also wouldn't have like a firm diagnosis. But what I do want to ask is, what would you be doing at this point? Would you, like, where would you be going to try and get more information? Because the key is that I don't know is a powerful thing for us to admit, as long as we can then go on to use our resources. So what would you be doing to try and help clarify your thought process?
So my favorite resource is up to date right now, but sometimes the residents are really knowledgeable and they're great resources to go to too.
I can help out here if that's okay.
And sometimes Dr. Abebe.
Yeah, say, Dr. Abebe, please do chime in.
So I think this case definitely illustrates that everything doesn't come as you expected, because initially when I looked at the history and the initial part, I was like, oh, this is probably going to be gastric outlet obstruction or some peptic ulcer disease issue, or maybe a mass. But as the case unraveled, it sounds like I feel, this patient probably has pernicious anemia, because, you can see that he has gastritis, pancytopenia, and remember, B12 deficiency can be a reason for pancytopenia and hemolytic anemia as well. And another point I was going to make was when you look at the total bili, it's high, and you find out that the LDH is high, and haptoglobin definitely, shows you there is some hemolytic process, and that also be in line with the fact that patient's bone marrow is not reacting appropriately for the degree of both anemia and degree of pancytopenia, if you will. So if I have to put my money, I would go with pernicious anemia. So we used to do what's called Schillen test in the past, but it's probably not something we do anymore. So it's kind of finding out what are the factors that are involved in B12 assimilation into your body. So you give with intrinsic factor. So if it improves, it's an intrinsic factor abnormality. then you give antibiotic, and if it resolves, then it's bacterial overgrowth. And despite both of those, there is no absorption. Then there is a problem with absorption, like maybe you have blunted villi in the case of like celiac disease. We don't do that anymore. I don't remember the last time that was done, but this is more of an educational purpose, and I'm surprised I even remembered it because I haven't done this or read about this for a while. So that's my point.
So you'd be surprised that no one's done it in a long time, but it's still on all their board exams. So, you know, it's not a bad idea to understand the concept. But as Dr. Abebe was alluding to, so one of the ways in which you can diagnose pernicious anemia is through antibody detection. So we actually have antibodies to the two things that you can really have antibodies to. So you can have it against intrinsic factor, which is produced by your parietal cells, or actual antiparietal cell antibodies. And our patient was found to have a very high titer of intrinsic factor antibody positive. So now you kind of have a slam dunk diagnosis. Like Dr. Abebe mentioned, you can have hemolysis. It's usually intramedullary. It's an issue with your ability to produce in your bone marrow. But you can also have some extramedullary hemolysis, which can be seen with elevated LDH and haptoglobin, and also your increased urobilinogen. And at the same time, like was mentioned, since it's an intramedullary production issue, you also will not have a reticulocyte count that is consistent with a destructive process, which you normally would see elevated reticulocyte counts in response to destructions happening somewhere. So that kind of points to a mixed picture. But, you know, some other things kind of before we talk about management, just to real touch on with B12 is that, you know, when you have a diagnosis like this, you also want to rule out any other causes of like a hemolytic anemia. So for this patient, you know, we want to make sure we don't have other causes of pancytopenia as well. So we also ruled out HIV, we ruled out hepatitis pictures with the, you know, bilirubin, we ruled out Epstein-Barr, CMV, and other infectious causes. And at this point, we also got our hematology colleagues involved as well. So we kind of think we have a diagnosis to a certain extent, and it's also been documented in the literature that you can have intractable nausea and vomiting as a source with a gastritis picture in pernicious anemia. It's not very common, but it is. So at this point, we're kind of thinking that's what's going on, but we still have to treat our patient actually. Like they're still sitting in this bed. We tell them we had the problem, but then, you know, what do you do essentially? So Jessica, if you were to kind of give an idea of some options that you have for treating symptomatically nausea and vomiting, do you kind of have an idea of what drug classes choices you might make?
So for just nausea and vomiting, there's the like Zofran, like the serotonin receptors, and then there's what's it like a prepitant or whatever, the chemotherapy, for more chemotherapy, and then there's I guess the dopamine receptors inhibitors too, like the metoclopramide, those kind of drugs.
Yeah, absolutely. So kind of the big classes that I think about are the antihistamine / anticholinergic. So those are kind of like your meclizine, your scopolamine. Those oftentimes help with central nervous system issues. So like dizziness, motion sickness. And then your dopamine receptor, there's kind of two different classes, ones that work peripherally and those that work only centrally. So the centrally is your common one that you'll see in the hospital is the compazine, or prochlorperazine, and then ones that also work peripherally and have like a prokinetic as well as the metoclopramide. It's hard to say. Metoclopramide. And then also, like you alluded to, the Zofran or ondansetron is a serotonin. And so it's really important, I think, as from a learning perspective as well, to think about what's the cause of your nausea and vomiting, and how can you treat that properly. So if you have something that's going on in your abdomen, you want to target something that's communicating between your abdomen and your area prostrema, which affects that. But if you have something that's going on with your inner ear, that's going from inner ear to your area prostrema. So you want to think about, that's why you want to use something that would be on those centrally acting pathways as well. And so that's why, you know, when you have some GI upset, like an enteritis picture, that's why those dopamine and serotonin pathways communicating from your GI to your central nervous system are very effective for those. So one question that is an incredibly difficult question, I think, for students, and I think I would love to hear Dr. Abebe's opinion on it, is when you have a patient like this, what do you use, Compazine or Zofran? I got pimped on this my third year.
Very good question. So remember, anytime you prescribe a drug, you need to know the side effect of every drug. So you have to counsel your patients on the potential etiologies of, or I would rather say the potential side effect or / untoward effect of medications. I can't emphasize that enough. And actually, one of my colleagues who in the gastroenterology, you know, tells me that he was in a deposition where a patient was on Reglan / metoclopramide and had a reversible extrapyramidal symptom / sign, and the physician actually, you know, was put at fault, although he was not the original prescriber. So be very careful and kind of counsel your patient. This is the first point. The next point is there are drugs that would help once you have the nausea and vomiting, and other drugs that actually prevent nausea and vomiting. So if you ask me, if the patient is already having nausea and vomiting, the ondansetron is probably not going to help. So I would probably go with prochlorperazine or the diphenhydramine, if you will. I would tell you there is no right or wrong answer when it comes to how to use nausea and vomiting medications. There are a whole bunch of medications. The other third point that I would make is always look at drug interactions. Unless proven otherwise, I would always think that any medication in the arena of anti-emetic would have a QT prolongation effect. So always be mindful of that. And the other big issue is, as you alluded to earlier, John, is why are they having nausea and vomiting? Is it like a short-lived versus a long, protracted course of nausea and vomiting? So you have to be very careful on peeling off other medications, and when you put a new medication, kind of understanding the drug reactions. I could go on talk, but I think this would be enough.
Yeah, absolutely. That's great. Thank you, Dr. Abebe. I think, you know, the way that I was originally taught was, if you kind of think about Compazine is kind of like a fast acting, I need something to hit me because I am acutely nauseous, versus Zofran is kind of like that, more of like a basal, you know, I don't want to get nauseous later. So sometimes patients say Zofran is not working for me, and that's partially because they just got it and they're acutely nauseous. So those are great things. One other point that I wanted to add, in that how we actually managed this patient, was he was not responsive to anything that we gave him initially. So we went to Ativan. And so benzodiazepines are another option for patients as well. And that's one that's not really taught. I didn't really learn that until I essentially saw it being used for nausea and vomiting in the hospital fairly consistently. Like Dr. Abebe had mentioned, there's, you know, those are not benign drugs. You know, you don't want to be giving those to lots of different patient populations. But for our patient, especially, he also, like was mentioned earlier, had a significant amount of anxiety surrounding eating. And we also were kind of the opinion that there might have been a psychiatric component to essentially his emesis issues after eating, because he had so much anxiety surrounding that. So his nausea and vomiting actually started to improve when we started Ativan on him. And one other drug that it's always listed is also just glucocorticoids. That's another thing that can help with nausea and vomiting. It's usually a different kind of clinical picture that especially if someone is having issues with appetite as well, that can also be used to stimulate hunger. And so you might see that in cancer patients at times, although oftentimes because they're immunocompromised patients, clinicians are not happy to start that quickly, but you might see that on a hematology unit. That's where I saw it used. And then, so now, you're kind of treating that nausea and vomiting, but you want to treat his underlying cause. So Jessica, do you have an idea of where you would go from treating his pernicious anemia?
So because we're thinking, pernicious anemia, he will not tolerate oral B12. So we're probably going to have to do injections.
Absolutely. That is a very important clinical idea about a B12 replacement. If you are thinking about the underlying cause, it's important to note that cause because if you are someone who have a B12 deficiency because, for example, you've been having a vegan eating pattern for the last 20 years and you have not had any B12, that's a classic. They like to talk about that, but that's extremely rare. But in that kind of picture where you have no issues absorbing it, like Dr. Abebe was talking about with the Schilling's test, then you can in theory replace with oral. However, something you'll see, and also if you're ever on a neurology service, they like to start with usually a week's course of intramuscular B12 injections, followed by a month a month of weekly B12 injections, and then transitioning to like a maintenance of once monthly as you continue to monitor those B12 deficiencies. You can also use oral B12 as well in certain instances in maintenance. But especially for our patient with pernicious anemia, he's going to chronically have to be on B12 injections for the rest of his life, which will probably be followed by his hematologist. Dr. Abebe, do you have any thoughts on B12 replacement?
I think Jessica nailed it. The only thing is that, if you have a documented absorption issue, you shouldn't try. But if you don't, then there is a room for trial of oral, B12. But I would throw a caution out there. The other thing I was going to say earlier that we didn't clarify and talked about was usually the MCVs are usually in the 1-teen. So in boards, they would put patients who have B12 deficiency as having MCVs in the 1-teens, not just 92, 95, or 100 for that matter. Just as food for thought. But I think you're actually putting it out there. I see the way I remember it is give daily for a week, weekly for a month, monthly thereafter is the way I would go about it. So, and then I think there are, let's say the B12 was kind of borderline. I don't know if you're going to talk about that. Like, if your B12 is less than 200, maybe that's a true B12 deficiency. Neurologist would stretch it to 300, so we'll have that in your mind. And normally you should expect it to be over 500. So if you have someone in between that gray zone, then you'd get the famous MMA and I'm kind of blanking on the other one, but kind of see whether the MMA is elevated in kind of diagnose B12 deficiency and differentiate it from folate deficiency.
Mm-hmm. Yeah, and homocysteine is the other one. And you can also use both of those as markers of response to treatment as well. It's not routinely done as much anymore because it's kind of like in this picture, that's a great board question, but that his B12 is undetectable. So in that case, you wouldn't as much. But if you want to see how the stores have been going overall, and also their neurologic standpoint, how they're doing. You can use methylmalonic acid as well, and I've seen that documented in literature looking at that. So in our absolutely.
Real quick, I just wanted to throw in there as well. I've seen this in a few patients where they have some sort of chronic, nausea, vomiting, something else where they just haven't been eating a whole lot. And like in your patient where they've lost a lot of weight, when you start fixing what's going on, be sure to watch out for refeeding syndrome. That can be a very fatal electrolyte abnormality that can happen, especially in the potassium and the phosphate, with someone who just is chronically malnourished, regardless of the cause, whether it's like an eating disorder, a nausea, vomiting, thing like this, anything. Just be very careful about that. It's total side note, it's a whole different topic, but just keep that on your radar.
Absolutely. That is a fantastic point. Thank you, Brianna. So to kind of wrap up our patient, so we started B12 injections on him, started Ativan. He started to improve a lot. And I remember the first day I came in and he had eaten an omelet, and he was about the happiest I'd ever seen somebody in the hospital. And it was like night and day. About 2 or 3 days afterwards, his numbness started to improve. He had no more nausea and vomiting. And it was presumed that was the underlying cause of his nausea and vomiting. And there's been a couple of case reports in which that's the underlying first presentation of B12 deficiency in young men is actually a gastroenteritis nausea and vomiting picture, though it's not as common. So with our patient, so you did a slam dunk diagnosis, you nailed it, you're treating him perfectly. Jessica, do you have any idea about what kind of follow-up someone with pernicious anemia does, and who does he need to see in the outpatient clinic? Do you have an idea?
Good question. I know that there is a higher risk for gastric cancer with these patients. I'm just unsure what the timeline is and kind of who. He does need a follow-up. I'm just not sure when or who or all that.
Absolutely. That is one of the biggest things that you'll want to do is make sure he is plugged in with the gastroenterologist, is because what the common practice, there is not a really set guideline, which is always fun when there's a billion different guidelines and different clinicians will do different things. But generally speaking, as quickly as or fairly soon after discharge, what you would like to do is do an EGD with biopsy of his gastric mucosa to look for pre-neoplastic lesions, because the pernicious anemia is it predisposes you to both intestinal type gastric adenocarcinoma, but also gastric, gastric carcinoid. And the underlying mechanism for that is because you have lower HCl levels, you actually have a elevated serum gastrin level, which actually leads to cellular metaplasia. So it's essentially you're knocking out your parietal cells. It's causing your body to say, I need more acid. It's ramping up the gastrin. It's ramping up the gastrin signaling, which leads to more parietal cells proliferating, which leads to, anything that's proliferating can lead to metaplasia and can lead to hyperplasia and then dysplasia. And so if you see on initial screening that you have pre-neoplastic symptoms, then you will likely be getting every 2 to 4 years follow-up of a continued EGD. However, if there's no neoplastic, depending on the guideline that you're looking at, if they're not symptomatic, so not showing signs of fullness or other signs that you may be having a tumor process, you really won't be getting EGDs done consistently, but that's very clinician to clinician specific. And I think a lot of KU physicians that I heard will do something around a 3 to 4 year interval regardless, especially if they are a younger patient where they have more time to potentially develop one of these cancers. So with our last little time, one thing I wanted to touch on, so Dr. Abebe really touched on a really, really important point with malnutrition with his vitamin deficiency. So we initially, I didn't mention this in this case presentation, but we saw that he had a coagulopathy when he came in. He actually had an elevated INR, and that was presumed to be secondary to vitamin deficiency from like a malabsorption or not enough intake whatsoever. And we also checked his other labs as well. So he was low in vitamin D, low in vitamin D, E, and A, all associated there as well. So we kind of toyed with, do we need to do anything to add in any vitamins and nutrition? And so that kind of made me think about one more question I had for Dr. Abebe is, so when you have a patient like this who can't take in any PO intake really besides fluids, at what point do you consider starting a core pack in a patient or an NG enteral feeding tube?
That's an excellent question. I think it all depends on the chronicity of a patient problem. If someone comes in and tells you they haven't eaten, you admitted them 2 days ago, you have the capability to wait for a week. But if someone has been nutrition deficient for a very prolonged time, like this patient, I think nobody's gonna fault you if you were to go ahead and try to feed this patient right on while also watching for refeeding syndrome. There is always, this is a gray area, to be honest with you. You see some waiting even longer, but I'm in a camp. If somebody hasn't eaten for over a week, I push on to get some sort of enteral nutrition. And I know, nutrition feeding enterally versus parenterally is another point of discussion for other time, but I would always opt for enteral feeding within 1 week if I can. I have stretched it. It's not like 1 week, 7 days. Maybe it's like if there is something that you're waiting for and patients plead not to have it, you may go for a few days more. But I think, you have to think of ongoing morbidity when patients are not getting fed, obviously.
Thank you. I think that's a really good point, and that's one of those clinical pearls that you don't really learn about. And I think I would encourage people, if they haven't read about TPN and indications for TPN and complications, you'll see a lot of, especially if you're on an oncology service or patients who have all kinds of issues, you'll see patients on TPN, and it's one of those kind of scary things that you say, I don't really know that I know that much about them. And there's complications to be had with those. Infections are a big one, as well as issues with triglycerides, pancreatitis. So there's other lots of things and it's a huge topic, but I would encourage you to kind of try to familiarize yourself with some of those different options that we have for patients who are needing additional nutritional supplementation. And then one final point that I wanted to add about pernicious anemia is that in addition to the screening for gastric cancers, that's important, there's also an increased prevalence in other autoimmune conditions. I don't have on me the exact odds ratios of, if you have pernicious anemia diagnosis, you'll have an increased likelihood to have these, but there is a increased association with type 1 diabetes, Hashimoto's thyroiditis, vitiligo, Sjogren's, celiac, and Addison's adrenal insufficiency. And those, if you kind of think about, oftentimes you think about type 1 diabetes, Hashimoto's, celiac, that classic triad. It's kind of within that triad of autoimmune endocrinopathy pictures as well. So you just want to be looking out for those. There's not a guideline for any screening with those, but there, when you have an association like that, don't don't be afraid to get a TSH and look for hypothyroidism in a Hashimoto type patient.
John, that was amazing. That was such a great case with so many, such helpful teaching points. And Dr. Abebe and Jessica, I just applaud you so much. I have nothing to add aside from so many teaching points. I will be going back and watching this again. If you didn't notice, I pretty much took up almost half of the screen with all of the teaching points that we had. So quick run through of some really big points that I think are really important to look at. Having kind of a good mental framework is always really important for any big diagnosis that you're trying to help your patient with. So for nausea and vomiting, Dr. Abebe gave us a wonderful framework of, is it in the GI tract, is it outside the GI tract, or is it a miscellaneous cause? And then he made the good point of, if it's an acute nausea and vomiting, rule out the deadly. It could be vascular. So think about stroke, MI, mesenteric ischemia, what could either kill or really harm your patient really quickly if you don't take care of it. Some other things that we talked about, when do you do a consult, making sure that you get some good groundwork in as far as your studies before you put in that consult so that your consultant has some stuff to work with. And when do you get an EGD? Really thinking about, is this likely a GI source? Could it be obstructive? Really thinking about what are you looking for with your test before you go ahead and order that test. A really good clinical pearl that Dr. Abebe gave us, if you have a picture of hemolysis, but you have a low reticulocyte count, sorry, this could have been John that said this, not quite sure, I'm mixing it up here, but think about pernicious anemia. If the picture's kind of mixed and doesn't make sense, don't just write it off. If it doesn't make sense, there's something that you're missing. Another big hint that we talked about was thinking about the localization of where your nausea and vomiting is coming from so that you can pick the best medication for your patient. If it's a GI source, your serotonin antagonists are going to be where the money is. So we're talking about ondansetron, that's the big one. If it's more of a vestibular or something kind of up in the ears or in the brain, or just if the serotonin antagonists aren't working, go ahead and move forward to an antihistamine or an anticholinergic. And then if it's more of like a brain mass or anything like that, or sometimes it's works really well for cancer patients, dopamine blockers can be really helpful. And then if nothing else is working, the benzodiazepines can be a great resource, especially if there's other things like a long QT or something else that makes those other meds pretty dangerous. And then last but not least, we hit on some really good points about B12 deficiency and replacement. Always make sure that you watch out for refeeding syndrome with nutrition deficiencies that are associated with nausea and vomiting and just not being able to eat a whole lot. You know, unfortunately, we don't want to risk our patients of getting worse by our treatment. So we always need to be careful about adverse effects of the treatments that we give our patients. And finally, remember, autoimmune disorders are very cliquey. They tend to always stick together and they don't like to separate. So if you have one, look for others and have a low index of suspicion for other autoimmune conditions. So with that, I thank you all for being here. This was an awesome discussion. Does anyone have any last minute comments?
I would say one thing, you know, nausea and vomiting is an overwhelming topic, especially if you see it in the hospital and it's not obvious what it is when they come in. You know, it's very nonspecific and there's the differentials extremely wide. So I would really encourage you to read, as a starting point, the up-to-date article on nausea and vomiting. They have a really great differential graphic figure that can just kind of break down every single different kind of cause, and kind of like we talked about, and breaking it up into the miscellaneous, the meds and other things like that. So that's a really good starting point to just kind of start with your clinical reasoning skills on the nausea and vomiting. And they also have some great figures about the different zones that drugs act and how the nausea and vomiting neurologic mechanism works. And I think it's really helpful to kind of get a feeling for, you know, why is this drug working versus a different one. We kind of touched on that, but I think I'm a very visual person, so I love figures, I love tables. So that's something that I really have learned a lot from.
Love it. Big takeaway. Zofran is not the end-all cure-all. All right, guys. This was a great discussion. Thank you all for being here. This will be up on YouTube shortly. And I know I'll be watching it again. So With that, have a great night. Thank you all.